Hi, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota. I'm preparing to apply into anesthesia, and I'm going over a few high yield anesthesiology topics that'll hopefully help you to stand out on your rotations as well as your upcoming away rotations. So, in this lecture, I'm going to cover the ASA standards for monitoring. These standards employ ECG, pulse oximetry, blood pressure, along with a few other things. So, in the first standard that the ASA has for monitoring, they say that a qualified anesthesia personnel shall be present in the room throughout the conduct of all general anesthetics, regional anesthetics, and monitored anesthetic care. And then the second standard for anesthesia monitoring encompasses 4 different areas. So there's a couple different methods for measuring oxygenation. The first one is on the anesthesia machine. There has to be a fraction of inspired oxygen analyzer, and that must contain a low oxygen concentration alarm. And then with all anesthetics, a quantitative method of assessing oxygenation. So in almost all cases, that's going to be pulse oximetry with variable pitch and tone is going to be necessitated throughout the case. Ventilation is measured primarily through capnography. Circulation is measured in at least 3 different ways. So all cases are going to have at least a minimum of a 3-lead EKG, and then that's going to be upgraded to a 5-lead EKG if there's any cardiac concerns. I'll say in my experience in Rapid City and in Sioux Falls, almost all cases include a 5-lead EKG. They're going to have a minimum of a blood pressure that's cycling at least every 5 minutes. And then there has to be at least one additional continual circulatory assessment. So normally that's going to be a pulse oximetry tracing because that'll show the pulse throughout the entire case, but it could also be an arterial line tracing or someone measuring a palpable pulse or listening to heart sounds throughout the case. Finally, if there's any concerns for anticipated changes in temperature of the patient, then there needs to be a temperature probe to measure any changes in these temperatures. So on the right here, we have an image of a Philips monitor. This sort of monitor is very common in both the Sioux Falls and in the Rapid City operating rooms. So just to hit on a couple of the high points of what we're seeing here. So this 60 in the top left in green, that's a heart rate that's derived from the EKG. The 95, that's your SpO2 level coming from your pulse oximeter right here. This is a waveform of your pulse oximeter. Seeing kind of anticipated waveform there really just tells you that you're probably getting an accurate reading and that you can trust this number that's a 95 right here. Likewise, here's your ECG reading. This number in blue right here, you can see that it matches the same blue as the 95. That's your pulse rate that's also coming from your pulse oximeter. So that would be one of the methods of continuous heart rate monitoring that we had mentioned in the ASA standards. These 2 numbers right here in red, those are pressures that are coming from blood pressures that are coming from your arterial line, and this would be your arterial line waveform. And then this number in yellow, that's your pulmonary artery pressures if you had a pulmonary artery catheter in, and then that's coming from your pulmonary artery waveform over here on the left. And then this number right here, that's your end-tidal CO2. So there's a few pros when you're reading an ECG, or at least knowing how to appreciate the leads. So if you're ever monitoring or you're concerned for arrhythmias, your best bet to monitor for sinus rhythm or for P waves is going to be observing V2. If you're ever concerned for ischemia, then your best bet to detect this is going to be V5. And say if you have a 3-lead ECG arranged, but you're concerned for ischemia, then you could take the left arm, move it to the V5 position, and observe V1. So to excel in the OR, in the PACU, at USD on your away rotations, it's going to be very important that you know and you're confident where to place the electrodes of an ECG. That's something that you can very easily do to participate in the care of a patient, to stand out in the OR, It's universally an option because the ASA standards require ECG monitoring for all anesthetic cases. So the most simple electrode placement for an ECG is going to be the 3-electrode system. Now, truthfully, I've never seen a 3-electrode system, but I definitely have seen a 4-electrode system. So a 4-electrode system just has a 4th green electrode down here in the right lower quadrant. Now, the most common mnemonic to remember the placement of the electrodes is going to be snow over grass, white over green, and then smoke over fire, black over red, and then white on right. So that way you can keep your sides organized in your mind. Now, the next step up from there is going to be the 5-electrode system, which has the same 4 quadrants that we just talked about. Then it also has a 5th electrode that's most commonly placed just to the right of the sternum in the 4th intercostal space. And then the most advanced ECG, you'll see this plenty in anesthesia, but certainly in the emergency department, or if you have any concerns of ischemia, if you're ordering an ECG to get a high quality reading. But this is going to be the 12-lead system. So again, this typically has your 4 leads in the 4 quadrants, and then it has V1, which is in the 4th intercostal space to the right of the sternum. V2, again, in the 4th intercostal space to the left of the sternum. From there, I would begin and I would place V4 and V6. So do V1 and then your evens. So V1, V2, V4, and V6. V4 is placed in the 5th intercostal space in the midclavicular line. So that's pretty easy to see. And then V6 is placed at the same level as V4. It looks a little bit more superior in this picture, but that's just because the rib cage is wrapping around. But it's also placed in the 5th intercostal space in the mid-axillary line, so that's going to be at the most lateral point of the patient. And then from there, you can, what I was trained, you can fill in the blanks by placing V3 in between V2 and V4, and V5 in between V4 and V6. So pulse oximetry uses the pulse ox clip that you see in every OR that goes on the patient's finger, and it reports a percent of saturated hemoglobin. So it's kind of interesting. You might get asked how this works. So just to give a very brief overview, on the clip, on like the top of the clip, you have a light emission source that sends out 660 nanometers of light, and then it fires that down through the finger that's within the clip, and then there's like a detection source down here at the bottom. And then you also have a light bulb that emits light at 940 nanometers of light, and it fires that down through the finger, and then it's detected on the bottom of the pulse oximeter. So it uses this to determine the percent of oxygen that's saturated with hemoglobin. How it does that is hemoglobin that's bound to oxygen absorbs light at 660 nanometers. Hemoglobin that is unbound to oxygen absorbs light at 940 nanometers. And then over here, you can see that your percentage of oxygen that's bound to hemoglobin is reported as your SpO2, and that's equivalent to your oxygen bound to hemoglobin over your total hemoglobin, which is composed of your oxygen bound to hemoglobin plus your normal hemoglobin. So this is going to be your oxygen or your hemoglobin that absorbs the red light, same with this, and then your unbound hemoglobin is going to be your oxygen that absorbs the ultraviolet light that I've drawn in purple. There's one caveat to this system that you might get pimped on. So you can see if this is arterial blood flow, this guy right here, I've drawn kind of like pulsating waveforms. Both of these, purple and red, are pulsating waveforms. The red, that demonstrates your oxygenated blood. The purple demonstrates your deoxygenated blood. This is arterial blood flow because it's pulsating. The blood then flows through your capillaries, which I've drawn over here, and then it returns through the venous system. And in the venous system, you have non-pulsating blood. You have deoxygenated, which is in purple. You have oxygenated, which is in red. Now, the pulse oximeter, it can determine if your blood is pulsating or non-pulsating. And that's important because then it can actually determine if your blood is arterial, if it's looking at the arterial pulsating blood, or if it's looking at the venous non-pulsating blood. It does this through a process called photoplethysmography. That's just where it can see the volume changes with the pulsation. And why that's important for pulse oximetry is because when we're talking about pulse oximetry and the percent of oxygenated hemoglobin, we really only care what that is in the arterial system. That's what we're talking about. So when it calculates this, it's able to isolate or control for the pulsating blood, or isolate the pulsating blood in the arterial system and then control for the non-pulsating blood in the venous system. That way you know that your SpO2 percent, maybe that's like commonly like 95%, is the percent of oxygenated blood in your arterial system. A few different factors can produce a falsely low SpO2 reading. So various dyes. The two most common ones are going to be methylene blue and indocyanine green. Those can produce a falsely low SpO2 reading if those are injected intravenously. Blue nail polish. And then shivering or other motion. Probably the most common one that you'll see is a malpositioned sensor. So if the pulse oximeter is falling off of the hand, probably the first thing you want to check if you have a low SpO2 reading, especially if you see an abnormal waveform. And then low perfusion. So perhaps someone is in heart failure, they have a low cardiac output state. They might have proper hemoglobin saturation, but you'll get a low reading on that just because of the low perfusion. A few things that I'd like to mention. Bilirubin has no effect on the SpO2 reading, neither does hemoglobin F or sickle cell. Acrylic nails, those don't affect it. Fluorescent dyes have no effect. And then, importantly, if you ever have seen cyanosis in patients, you probably won't forget that. And that occurs around SpO2 less than or equal to 85%. So how do methemoglobin and carbon monoxide affect the SpO2 measurement? So methemoglobin is going to produce an SpO2 reading of about 85%, regardless of their actual oxygenation status. So if a patient has a normal oxygenation level around 95%, then it's going to read falsely low because it's still going to read 85%. However, if they're hypoxic below 85%, then it's going to read falsely high because it'll still read 85%. There's a couple different things that can cause methemoglobin. In the anesthesia world, prilocaine or benzocaine topicalization can cause methemoglobin. Metoclopramide can cause methemoglobin, same with dapsone, nitric oxide, nitroglycerin, those all can. You're going to treat methemoglobin using methylene blue. And then carboxyhemoglobin causes a falsely high SpO2 reading, around 95%. So this is almost always going to be falsely high, and it can be caused by smoke inhalation, volatile anesthetic degradation, and then treat it using 100% inspired O2 and then hyperbaric oxygenation if needed. So a non-invasive automated blood pressure cuff uses a technique called oscillometry to measure blood pressure. So if you imagine in our patient's arm, they have arteries. That's what I'm drawing here. And in the arteries, they have blood flow that goes through the artery. And with each pulse, each heartbeat, the blood exerts a pressure on the walls of the artery. And then when we want to measure their blood pressure, we take a blood pressure cuff, wrap it around their arm, and in this blood pressure cuff, there's mechanical sensors that can sense each pulse against the wall of the artery. And these pulses create oscillations that the blood pressure cuff then picks up. So when we first place the blood pressure cuff on the patient, it inflates to a very high pressure, and it really clamps down, like you can see down here, really clamps down on the walls of the artery. Now you can imagine, because it's so tight and it's clamped down, there's very limited blood that can actually flow through the artery like this. There's not very much. So because there's reduced flow, the sensors that are here in the blood pressure cuff, they pick up kind of a minimal or very small amount of oscillations that are occurring through that artery. On the other end of the spectrum, when the blood pressure cuff begins to deflate, you still have blood that's passing through the artery, and you have these sensors on the walls of the blood pressure cuff, but they're not in as close of contact with the blood that's flowing through the artery. So they also sense these oscillations caused by the pulse, but to a less degree. And it just so happens that blood is flowing through the artery right here. I've given at a mean arterial pressure of 65, and the sensors of the blood pressure cuff are in just the perfect amount of contact with the wall of the artery. And there's the pulse that's exerting the pressure, and it's creating oscillations that these sensors are then picking up. Where the oscillations are detected at a maximum amount right here, that's going to be the mean arterial pressure. So in this diagram over here, you have a kind of a minimal amount or a small amount of oscillations. These are oscillations that are being detected. And then on this side, you also have kind of a small or minimal amount of oscillations that are being detected. But right here in the middle, you have the maximum amount of oscillations that are being detected because the cuff that's around the patient's arm is in the perfect amount of contact with the wall of the artery. So then you can, at this point, this is the mean arterial pressure. You can use that to derive the systolic and diastolic pressures. The two things that can kind of influence or make this measurement inaccurate is if you have too small of a cuff, it's going to be too tight, you're going to get too high, falsely high pressure readings. And if you have too large of cuff, it's going to be too loose, you're going to get falsely low pressure readings. So there's a couple different indications for invasive blood pressure monitoring. Probably the most common is if you want moment-to-moment or beat-by-beat assessment of blood pressure or blood pressure monitoring. Otherwise, in some cases, you might be doing pharmacologic manipulation of blood pressure, or if it's very important to reduce or keep strong blood pressure for different points in the case. So we'll just call that manipulation of blood pressure. Then you could consider placing an arterial line. In heart cases, oftentimes they'll draw blood samples off of an arterial line. And then if you first tried non-invasive blood pressure monitoring, but that failed for whatever reason, if the equipment's not working, if the patient's not conducive to that, then you could opt for invasive blood pressure monitoring. And then sometimes an arterial line can provide supplementary data. So that could be like looking at pulse pressure variation to guide the volume status of the patient. I hope that this lecture helped you guys. Hopefully it provides just a little bit of a background into some of the more fundamental aspects of anesthesiology and of monitoring and care within the OR. Feel free to reach out if you have any questions. I'm sure myself, Dr. Toom, Dr. Smith would all love to answer any questions. Good luck.